Thank you very much for the kind introduction, and good evening, ladies and gentlemen, and greetings from Sri Lanka. First, before starting this presentation, I would like to say a big thank you to the organizing committee for the invitation for both of us from Sri Lanka. And this is a topic close to my heart. I have been working with the patients with thalassemia for the last 10 years or so before I became a consultant. And during this past 10 years, I've seen many patients struggle with a lot of complications from thalassemia, a lot of complications from endocrinopathies, struggling to survive, and I've seen many die as well. So I think as clinicians, we have a responsibility towards, because their lifespan is getting now increased in thalassemia, it's our responsibility to make sure that we control their endocrinopathies very tightly to increase their quality of life and survival as well. So my topic is navigating the dual challenge, managing diabetes in patients with thalassemia. Bit of word about thalassemia. It's the most common inherited hemoglobinopathy with an autosomal recessive pattern. And it's a globin chain mutation that leads to thalassemia and caused by either partial or complete impaired production of one of the globin chains, which will lead to either alpha-beta imbalance, ineffective erythropoiesis, and chronic hemolysis. Alpha and beta thalassemia are the most two common forms, but they have E-beta thalassemia, thalassemia intermedia as well. It's very common in Sri Lanka as well. Out of these, beta thalassemia major is a form of thalassemia with a prevalence of about 1.5% of the world population. You can see it has a bit of a prevalence as well. And to talk about Sri Lankan burden, we have currently about 2,500 patients and estimated to give 40 to 60 new births per year. And as majority, 60% thal major and 30% E-beta thalassemia, and rest of the two other varieties. So I work in this HEMA's adolescent and adult thalassemia care unit attached to Colombo North Teaching Hospital, Sri Lanka. And that's the only adolescent and adult, both together, care center in South Asia, caring for about 500 patients of major, thal major, intermediate, and other types as well. To talk a bit about global prevalence, you can see the band of prevalence, and including the subcontinent, Indian subcontinent, and the sub-Saharan, and to the African and American, South American as well. The Indian prevalence ranged from about 2.6 to 13.2% in various studies, where North and I think West have the highest prevalence in India with the thalassemias. So why are we so worried about this connection? What is the connection between thalassemia and the endocrine system? First, to talk about that, let me talk to you about hepcidin. Hepcidin is a small peptide which inhibits the iron absorption in the small intestine, and both the ineffective erythropoiesis and anemia in thalassemia will result in down-regulation of this hepcidin. So in spite of these patients having elevated iron stores in thalassemia, reduced expression of hepcidin will lead to increased iron absorption for them from the intestine, causing iron overload. So this having dual pathology and increasing the iron overload in these patients. With this continued accumulation, the monocyte macrophage system gets saturated and excess iron gets deposited. Where does it deposit? It deposits in liver, heart, pancreas, endocrine organs such as pituitary, thyroid, parathyroid, adrenals, leading to tissue toxicity. So you can see, when I see a patient complicated with these endocrinopathies, it's like just reading a textbook from pituitary to thyroid to parathyroid, adrenals, all been affected. I've seen all of it in one patient in one go as well, developed subsequently during their lifetime. So by overloading these endocrine organs, which leads to cellular dysfunction, cytotoxicity, and ultimately will lead to cellular death. And chronic hypoxia and viral infections are also thought to play a part of this pathology, and deficiency of a variety of hormones will carry on depending on the organ affected. So these are the main endocrine complications we see in these patients: growth failure, hypogonadism, diabetes, hypothyroidism, hypoparathyroidism, adrenal insufficiency, primary and secondary both, and osteoporosis or low BMD, depending on their age and sex. So this is a study done in our center, and you can see delayed puberty was the commonest form of endocrinopathy, and hypogonadotrophic hypogonadism next being 51.8%. Diabetes hanged around 16.3% of our population of TALS patients in our center. This is a group of medical professionals, international network on endocrine complications in thalassemia called ICET, where Sri Lanka is also part of this group, where our center gives data for these studies as well, and they have guidelines in managing patients with endocrine complications in thalassemia. So I'm going to get you to a case, one of the most interesting cases I had during the past few years. He is a 28-year-old male, had beta thalassemia since the age of 3 months, and developed hypogonadotrophic hypogonadism and delayed puberty at the age of 13 years, and subsequently developed hypoparathyroidism, and lastly developed diabetes about 3 years back. Before developing diabetes, he had impaired fasting glucose, which was diagnosed with the OGTT, but he was unable to comply with the advices. His serum ferritin was 2,500 when we diagnosed him with diabetes. Let me come to my talk on diabetes and thalassemia. It's a significant complication in patients with beta thalassemia, and the estimated prevalence, as variable, as I said, is about 16% in our population, but varies from 1% to 21%, depending on the center these studies were done across the world. So what makes them diabetic, these thalassemia patients? The transfusional iron overload is the key factor which damages the pancreatic beta cells. And this poor compliance with chelation therapy leads to iron overload. And the advanced age where the chelation started also has an influence on this endocrine complication of diabetes. Apart from that, altered B cell insulin secretion and also autoimmunity had been found to have been playing a part, where they have found that immune system in thalassemia patients is downregulating, and their autoimmunity comes up, and they can develop type 1 diabetes in thalassemia patients. And specifically, the liver disease and the hepatitis C infection can cause insulin resistance, and this insulin resistance develops far ahead of developing diabetes in these patients over time, and then they develop diabetes. Family history of diabetes, of course, age, lifestyle, obesity also plays a role. So you might think thalassemia patients as short, lean patients, but no. I've seen many obese thalassemia patients as well, depending on their lifestyle, which they are having currently. So these are the main etiological factors why your patients with thalassemia can have diabetes. So how do we screen these patients? So this is usually seen after about 10 years of age, and monitoring starts around that age with 2-hour oral glucose tolerance test. We do the OGTT. Should be performed at age 10, 12, 14, and 16, and annually thereafter. Can we do HbA1c? As our chairperson said, it's a controversial thing because we cannot, because they have low hemoglobin, and we're unable to do these test limitations. So we do fructosamine in these patients, but not for diagnosis, but mainly for monitoring purposes. But we carry on the OGTT. So what is the purpose of having a screening for these patients? One is early detection. We can diagnose them to have impaired fasting glucose. And also, if we diagnose them with diabetes, we can reverse it, because I've seen that if you control their iron overload and having a good intensification of their chelation therapy. So it is useful that we screen these patients and prevent them from going into frank diabetes. This was a study, again, from the ICET study published very recently about doing OGTT in thalassemia patients, published very recently, I think in December, where we also gave data where all publishers said Some of the countries just do the OGTT as required, but few countries still are yet to do OGTT and still relying on their fasting blood glucose or postprandial blood glucose for diagnosis, which is not the correct way of doing it. So how do we manage these thalassemia and diabetic patients? As in all diabetic patients, lifestyle modification with good dietary modification, exercises, and pharmacological management. There are issues with dietary and exercises in these patients. They are anemic, and sometimes they go into low HbA of 6, 7 sometimes, and advising them to exercise during this period is not very healthy for them. And diet-wise also, they are restricting some of the iron-containing food, but when we ask them to control their carbs, they do that. But as Malika said, in Sri Lanka, having a big rice plate is very important for all 3 meals, and getting that reduced is definitely a challenge for us to control their portion sizes. So can we use drugs in these patients, oral drugs? Yes. There are studies that used metformin, glibenclamide, and acarbose in these patients, and mostly metformin. We use metformin as well in our patients with resistance, insulin resistance with facial features. We do start them, and especially for even impaired fasting glucose, we start it with the lifestyle modification to reduce the progression, and with type 2 to control the diabetes as well. And there is about 20 to 30% of patients with diabetes are managed only on oral drugs. But you can see that majority will need insulin because they have destruction of the beta cells and they are unable to produce their own insulin. So how do we monitor these patients? We need to screen them for end organ damage, similar to other patients, but we see less nephropathy and less neuropathy in our patients, and probably because they are having this gonadal dysfunctions as well, which can contribute to this factor. And the glycemic control is assessed periodically with home blood glucose monitoring. We do the glucose monitoring. We don't have CGMs in Sri Lanka at the moment. And the fructosamine target is 287, less than 287, which is equivalent to about HbA1c of 7. So this is to recap what the fructosamine and HbA1c looks like. You can see HbA1c 7 is 287 and 10 is about 400 of fructosamine. And there are studies saying that it may not correlate well as well, but this is good as we get in managing and deciding on their treatment regimes for us. Is there psychological impact? Yes, unfortunately, because these patients living with diabetes and thalassemia have major psychological impact due to feeling of treatment burden. They are on treatment for iron chelation, they are on monthly blood transfusions, and some are managing hepatitis infections, and some are managing other organic failures, and then coming with diabetes and 3 or 4 insulins a day. It makes their life hectic. Impact on daily life, feeling of difference, dependence, a feeling of damage and anxiety is among the psychological things we need to consider in our patients. So I'm continuing my case. He had a fructosamine of 467. That was about 6 months back. He was on premix insulin. You can see high doses, 45 units twice daily with a soluble for lunch with metformin. But later, we could change them to the basal bolus regime. That's from a donation from Australia given for young children. And he was enrolled into this and young adults. And he was given the basal bolus regime, but still with poor compliance. He did not manage his diabetes well, missed his lunch doses, and so on and so forth. What happened very recently was 2 months back, he developed acute coronary syndrome. Young patient, 28. He had T inversions in anterior and inferior leads. Troponin was positive, but his 2D echocardiogram showed no LV dysfunction with mild TR only. So what are the causes for this cardiac disease in beta thalassemia? Multifactorial, iron overload, chronic anemia, hemolysis, inflammatory factors, immunogenic factors. All of that will have them to have cardiomyopathy, pulmonary hypertension, arrhythmias. premature vascular aging and peripheral artery disease, and sudden cardiac death. And I've seen many patients die of cardiac complications when they're iron overloaded, and especially when their diabetes is not controlled. The challenges I've encountered and thought I would like to share with you in this audience when managing patients with diabetes and thalassemia is the compliance to treatment, because they have issues, as I said, with their chelation therapy and diabetes. It's very challenging to convince them to get into regular regimes and getting them to regular clinics. My patients come far away from all the corners of the country to one center for monthly transfusions and for endocrine care, and it's exhausting them. Behavior of the disease is variable among patients. One patient to one patient is so different, and individualizing your management is the key. And these patients have rapid blood glucose fluctuations, are very unpredictable. I currently have a patient who goes into 20 of blood glucose at night and 400 at lunchtime, and on analog insulin from a donation, still going into severe hypo. I think she would benefit from having a pump, which we can't afford at the moment. So rapid fluctuations are there in thalassemia patients. And these patients have poor immunity due to hyperglycemia, and which leads to increase in their mortality and morbidity both. And this immunity needs to be increased with controlling their hyperglycemia and controlling their iron overload. Of course, the poor resources of we are getting free treatment for these patients. Only we can afford to give the mixed insulins and a soluble. We cannot go for basal bolus regime, which would have been the ideal for all patients with thalassemia in our country, but it would have changed some of the patients' lives as well. I'd like to acknowledge Professor Anuja Premavardhana. He's a key consultant physician looking after these patients. He's a professor of medicine in our faculty, and all the staff of FEMA's Thalassemia Center, which is doing a wonderful job with these thalassemia patients, caring for them with their diabetes and all the other complications, and to all the courageous thalassemia patients who are surviving in a day-to-day basis. And we can stop thalassemia. It's mainly due to consanguinity and genetics that we have to advise them to go for the testing prior to their marriage, and to improve this knowledge across. We have a lot of preventive programs in Sri Lanka as well, so we can prevent thalassemia and prevent the endocrine complications and diabetes as well. This is from our website, from our unit. This is written by one of the patients. Yes, we are thalassemian, but we want to live long lives. Thank you for listening.